This is the Daily Medical News by MD Edge, where we bring you the top stories in clinical medicine, followed by a deeper dive into the day's top story. Today is Monday, September 30th, and I'm the voice of MD Edge podcast, Nick Andrews. Today, we continue our coverage into the emergent lung disease linked to vaping. The CDC is reporting that most vaping lung disease is linked to vape cartridges that contained THC. But before we get into the news, a quick update onto what's going on at MD Edge Podcasts. For those of you that don't know, we are a print and digital media company owned and operated by WebMD and Medscape. We cover medical news from our journals and meetings. Our coverage is meant for clinical physicians and those who treat patients. This week, in our lifestyle podcast, the Post Call podcast, Dr. Emily Silverman is the guest. Dr. Silverman is the founder and creator of the Nocturnists podcast. She joins me to talk about the show and peel the curtain back on her process and where the show is headed. You can find a link to Post Call in the show notes. And now, the top stories in clinical medicine. We begin today with a legislative battle over drug prices. Legislators sparred about the best way to lower drug prices during a hearing on September 25th, bickering along partisan lines over new legislation by U.S. House Speaker Nancy Pelosi. The legislation would require Medicare to negotiate drug prices with manufacturers. The legislation is H.R. 3 and is titled the Lower Drug Costs Now Act of 2019. The law would compel the Centers for Medicare and Medicaid Services to make deals with manufacturers on the maximum reasonable price for the top 250 highest cost drugs. If a drug maker refused to participate in the negotiation, that company would face a steep non-compliance fee. The legislation would also impose a civil penalty for manufacturers who overcharged Medicare or who failed to offer the negotiated price. For patients, the legislation includes a $2,000 out-of-pocket limit for Medicare patients. During the meeting, one economist said that allowing the federal government to negotiate prices for expensive drugs without competition in both the public and private sectors will be more effective in lowering prices. But another economist who spoke at the meeting said that this legislation could reduce innovation. He said that drugs that have no competitors would be subject to aggressive rate regulation. This is not true of drugs that have at least one competitor in the market. It is possible that being a second market entrant could be substantially more profitable than bringing a novel therapeutic to market. You could read more thoughts from both the legislators involved and the economists who spoke at the meeting by clicking the link in the podcast notes. And now we look at alcohol intake and dementia risk in older adults. The amount of alcohol drank and the frequency of intake correlate with cognitive decline and the risk of dementia among older adults. Researchers also report finding that mild cognitive impairment may influence the relationship between alcohol consumption and dementia risk. This is according to new research published in JAMA Network Open, in which researchers evaluated data from the Ginkgo Evaluation of Memory Study, also known as GEMS. GEMS was a randomized controlled trial between 2000 and 2008, which found no overall association between ginkgo biloba and dementia prevention. In this study, the investigators analyzed data from a little more than 3,000 participants who were 72 years old or older who were free of dementia at baseline. They defined light drinkers as those who drank less than one drink per week on average. They report that among 473 participants who had mild cognitive impairment at baseline, the adjusted hazard ratio was 1.72 for those who consumed more than 14 drinks per week, compared with those who drank less than one drink per week. The researchers noted that limitations of the study include a lack of data about any changes in alcohol consumption over time. They also recognized that the original trial excluded people with a known history of excessive alcohol use. Palliative care programs continue to grow in the U.S., although access to palliative care depends more upon accidents of geography than it does upon the needs of patients. This all comes from data from the Center to Advance Palliative Care and the National Palliative Care Research Center. Dr. Diane E. Meyer is director of the Center to Advance Palliative Care. She said that, as is true for many aspects of healthcare, geography is destiny. Where you live determines your access to the best quality of life and the highest quality of care during a serious illness. In 2019, more than 72% of U.S. hospitals with 50 or more beds have a palliative care team, compared with 67% of hospitals in 2015 and 53% back in 2008. What hasn't changed, however, is the country's overall grade, which remains a B. Delaware, New Hampshire, Rhode Island, and Vermont have a palliative care program in all of their hospitals with 50 or more beds, and each earned a grade of A, along with 17 other states. The lowest performing states, Alabama, Mississippi, New Mexico, Oklahoma, and Wyoming, all received Ds for having a rate below 40%. The urban-rural divide also is prominent in palliative care. 90% of hospitals with palliative care are in urban areas. Only 17% of rural hospitals with 50 or more beds report palliative care programs. The report card is based on data from the American Hospital Association's annual survey database, with additional data from the National Palliative Care Registry and the Center to Advance Palliative Care's Mapping Community Palliative Care Initiative. The Daily Medical News. We'll be right back after this. Welcome back to the Daily Medical News. I am Nick Andrews. A district court has dismissed a lawsuit levied by a group of physicians against the American Board of Internal Medicine over its maintenance of certification program, calling the legal challenge flawed. In a September 26th decision, U.S. District Court Judge for the Eastern District of Pennsylvania, Robert F. Kelly Sr., said the plaintiffs failed to demonstrate sufficient evidence for their antitrust and unjust enrichment claims against ABIM. The doctors also did not establish any showing of anti-competitive conduct by ABIM to support a monopolization claim, the judge ruled. Judge Kelly wrote that not only are we unconvinced by the plaintiffs' arguments, we find that the plaintiffs' entire framing of ABIM certification to be flawed. In essence, plaintiffs are arguing that in order to purchase ABIM's initial certification, internists are forced to purchase MOC products as well. However, this is not the case. Nowhere in the amended complaint do plaintiffs allege that they were forced to buy MOC products in order to purchase the initial certification. Those are the words of Judge Kelly's ruling in writing. The judge dismissed the suit but allowed the plaintiffs 14 days to submit an amended complaint re-outlining their claims of illegal monopolization and racketeering against the board. If the amended complaint passes legal muster, the judge could revive those claims. C. Philip Curley, a Chicago-based attorney for the physician plaintiffs, said the case is far from over. Quote, the 4 internists who brought the lawsuit were invited to file amended claims, which is certainly being considered, unquote. The attorney also said if necessary, all available appeals will be pursued to the fullest. No one was under the impression that the fight to bring MOC to an end would be quick or easy. And finally today, a deeper dive into the emergent vaping lung disease. The CDC reports that more than 75% of patients with vaping-related injuries used at least one product that contained THC before those patients developed symptoms. Also, most products that were used were prepackaged, pre-filled cartridges. 66% of these cartridges were THC-containing products that were marketed under the brand name Dank. Dank cartridges are available at legal dispensaries and online in areas where they are legal. The Dank company posted a statement on its website warning buyers about fake cartridges and showing images of genuine cartridges. However, 89% of the cartridges were obtained on the street, from dealers, online, or from friends or social contacts. The illness was first recognized in Wisconsin and Illinois. Marijuana is legal in Wisconsin, while Illinois licensed recreational marijuana in 2009. Dr. Ann Schuchat is deputy director of the CDC. She said that there are other commonalities in the cases. In fact, more than 2/3 of the 805 confirmed or probable cases were male, and the median age was 23 years old. The illness also crosses age barriers. About 62% were between 18 and 24 years old, and more than 54% were under the age of 25. However, among the 12 deaths reported at the time of this recording, the median age was actually 50 years old. Other clinical commonalities include intensive use of THC-containing products and, in a small number of cases, a concomitant use of benzodiazepine, opioids, and narcotics. Cases have now emerged in 46 states and the U.S. Virgin Islands, although the number reported each week is dropping. However, this decrease may not represent a drop in newly occurring cases, but instead reflect delays in clinical recognition or reporting to local health departments. Dr. Shukant said that despite her recent decline in reported cases, she said the epidemic is serious, far-reaching, and it is ongoing. She said that she wants to point out that this is a serious, life-threatening disease that is occurring mostly in otherwise healthy young people. She continued by saying that these illnesses and these deaths are occurring in the context of a dynamic marketplace with a mix of products with mixes of ingredients, including potentially illicit substances. Users do not know what's in them and cannot tell them apart from the ingredients listed on the packaging. And that concludes this edition of the Daily Medical News. Remember, you can find links to the digital versions of all of these stories online by clicking the link in the podcast notes. For MD Edge, I'm Nick Andrews.